I think we're going to get going on our Quest for a Cure seminar tonight. So welcome to the Quest for a Cure Progress in Cancer Research Starlight Lecture Series. I want to thank everybody for joining us tonight. This has been an exciting series for us here. And today's is going to focus on brain cancer research. So I'm Joe W. Ramos. I'm the Deputy Director here at the Cancer Center. I do brain cancer research myself, and I'm going to be the host for you this afternoon in this webinar. Please note the webinar is being recorded, and the recording along with the presentation slides will be posted to the UH Cancer Center website as soon as they're available. You'll see that the chat box is turned off, but if you'd like to submit your questions, please do so using the Q&A box instead. You'll see that is also at the bottom there. And so we'll be monitoring questions in our Q&A box, and we'll get to those at the end. Also, there'll be a survey link that's going to be displayed in the chat box during the Q&A session, and you can provide feedback there. But there'll also be an email sent to you the next day with a survey link in that. And there will be a special thank you if you fill out the survey with a little Mahalo gift mailed to you. All right, so as I said, tonight we're focused on brain cancer. So you may or may not know this is a fairly rare cancer. We have about 67 adults diagnosed annually with this brain cancer or other nervous system cancers in Hawaii, and that's each year. Approximately 70% of those individuals do die from the disease. So this is a very nasty brain cancer, nasty kind of tumor, and in dire need of new treatments and new therapies for the more advanced kinds of brain cancers. You'll learn tonight that there are a number of different kinds of brain cancers, and each one has its own challenges. And so we're going to just jump into it. We're really lucky to have Dr. Thomas No and Dr. Christina Spires with us. I'm going to go ahead and introduce first up in our series is Dr. Thomas No, who's a neurosurgeon from Kapiolani Medical Center for Women and Children, Palimomi Medical Center, Straub Medical Center, and Wilcox Medical Center. He was born and raised here in Honolulu. Completed medical school at the John A. Burns School of Medicine here across the way from me. Trained at the Henry Ford Hospital after that and pursued a fellowship in brain tumor surgery at Harvard's Brigham and Women's Hospital. He's currently an assistant professor in the departments of surgery, anatomy, and medical education at JAPSOM, and he has a lab focused there on surgical innovations. And so without further ado, I'm going to turn it over to you, Dr. No.
Great, thanks for that introduction, Joe. So let me see, I'm going to share my screen here. Let's see. Is that working?
Yes.
Great. Okay. So, so I just wanted to go over some of the surgical adjuncts that we use for brain tumor surgery. Again, especially in this day and age, I feel very sort of fortunate to be working where we can do this sort of rapid data transfer. We can do these Zoom meetings. We can do and stay very interconnected, even at our own computers. And I think this is really where technology is sort of outpacing our ability to even understand, things like deep learning. And so as clinicians, I really feel that there's like an immense opportunity and an advantage for us to really innovate and come up with new solutions. And so again, my interests lie in developing better tools to do better surgery, basically, for all kinds of brain tumors. But I really wanted to take the time today to talk about a specific type of tumor and really use it as an example of how we do better surgery in the brain. This is, many people may not recognize this, but this is an MRI of the brain with a tumor that sits in a somewhat eloquent area in a sort of important part of the brain. And what I want to show you today is how we apply some of the surgical concepts basically to trying to take out these tumors and to cytoreduce or reduce the number of cells that are in the brain and that are causing the cancer. And so again, this is one of the more challenging tumors that we face. This is what we call a glioma. And this one is likely high grade. The prognosis of something like this is very dismal. And although surgery is an established paradigm in the treatment of this disease, one of the challenges that we face as surgeons is balancing gross total resection. In other words, trying to get all of that white stuff that sits in the bottom right corner with basically over resecting or causing deficits. And so today I wanted to go over some of the tools that we use to basically help us treat these tumors, as well as some of the innovations that we're developing. So in 2019, the American Cancer Society estimated about 24,000 new cases with about 18,000 deaths. Gliomas as a whole account for approximately about 27% of all primary brain tumors, and with about 56% of these cases being GBMs, which is the most dreaded form of glioma. And again, GBM stands for glioblastoma, which is the most aggressive form. Survival time, after diagnosis varies significantly by grade. I don't want you to pay too much attention to all the little, variations, but more recently, efforts in precision medicine have allowed us to determine important prognostic mutations in these tumors. And so treatment options these days are actually based on their molecular features sometimes. And so talking a little bit more about prognosis, as I mentioned earlier, the majority of gliomas, they carry a pretty poor prognosis. And this is something around the 5-year survival of about 5%. The best therapy that we currently have is the current standard of care, and it's called the Stoop protocol, which is basically, it's a short name basically for a series of surgery, radiation, and chemotherapy. And so for newly diagnosed GBMs, surgery is followed with this sort of paradigm. And the median survival, again, even with this, is on average a dismal 12 months. And this is really the main reason that gliomas are challenging, is that because they're a very infiltrative disease. They're constantly changing. And another problem is that they have really different types of molecular markers. And that can make finding a sort of final common pathway really tough. And so that means that even though we saw that one picture that had that little bit of contrast leakage, you basically already have tumors spread out through the entire brain. And many times it's just a red herring because the tumor has already diffusely spread and oftentimes mutated even. But, despite the slow progress, the average survival for patients has increased steadily, just even over the course of, say, 10 years. And I think this graph itself it's actually a bit dated, but it only takes into account the average survival, which is up to 2010. So that makes this about 10 years old. But I do believe that a lot of this is due to the evidence and sort of the evidence-based, surgical and oncologic changes that we've made. Things like even multidisciplinary tumor boards, which we do now here in the HPH system, and personalized medicine. And these things really, even though it's just something as easy as collaboration, has played a central role, and I think is crucial to raising this survival curve. And so one of the examples of things that I've worked on before, it really is towards moving towards options that may be a little bit outside the box. And this is just one of those examples. This is what we call the Exablate blood-brain barrier disruption trial. And that's really a fancy way of sort of saying we used ultrasound to sort of open up some of the blood vessels in the brain, which then allow chemotherapeutic agents to actually infiltrate the brain better. And so by getting more chemotherapy, the thought is if you can get more chemotherapy into the brain, then perhaps that chemotherapy may be more effective and attack the tumor better. And so this is a technology that basically concentrates the ultrasound. You give patients an IV bubble type of solution, and then the bubbles actually oscillate within the blood vessels and open up the channels in between them and cause more leakage basically of chemotherapy. But again, this is not something that we do routinely. And so, this is a clinical trial that I'm a part of at the Cancer Center, where, again, we're taking some of these patients and we're giving them the standard of care, which is what I mentioned earlier of surgery, radiation, and chemotherapy. But then on top of that, adding a new type of chemotherapy that's found to sort of be really robust in some other types of cancers, and sort of just asking the question, well, if we added on these other types of drugs, does this potentially increase survival? And that's an unknown. We really don't know. And so that's why these clinical trials are so important towards finding better therapies and better cures for these patients. So going back to the same patient, we know that, the Stoop protocol, again, is surgery, chemo, and radiation. And what I want to touch on for the next few minutes is how surgery is actually the most modifiable pillar of these three things. And And so the reason why I wanted to emphasize this slide is, and again, I don't want to bore you too much with all of the data and all of this, but as our imaging techniques have improved over time, we have an ability now more than ever before to help ourselves in resecting some of these tumors, and very innovative tools that can help us guide and pursue a maximally safe resection. And you can see how important that is, because people who have some type of deficit, whether it be a language or motor, they just do less better overall. And so it's really important for us as surgeons to sort of take care and try to get as much of the tumor without causing any problems. And so this patient again, just as an example, how do we get to that tumor? Well, we use things like neuronavigation to help us get there. And what this is basically a combination of a camera and some trackers in space, much like the same things that show up in video games, to basically give us a GPS system for the head. And this takes into account very simple things like these contrast-filled bubbles, or things like the anatomical features on a baby's face, nasion and tragus. That's my daughter helping me out with my presentation. And then, what we've done, for example, in my lab is sort of push this technology forward a little bit by saying, well, this machine is quite bulky and big. And we have things like iPhones that can recognize our face way better than that thing can. So why aren't we using that technology? And these are the simple questions that we can ask to sort of advance things and push things forward. And we've taken that even a step further by being able to take anatomical things and put them basically into a space. And so you can imagine being able to do things like, for example, show people their tumors and where it is relative to their brain, or even use these things in the operating room to give us a better idea about where the tumor is relative to what we're seeing. And so we're really pushing things like even basic things like neuronavigation to new levels. Intraoperative MRI is another thing that's important for us, an important tool for us to have. What it does is it basically helps us to get an MRI right after we're done with our surgery. And what we can do is, identify things like an incomplete resection. After the MRI is obtained, we can actually re-register our GPS system. And this is really helpful for things that sometimes don't show up to the naked eye. So for example, when we open up a brain, oftentimes there's tissue in there that that looks just like normal brain, but is actually tumor. And so that's where sometimes tumors can be missed. And so this is why the intraoperative MRI is so helpful, and why I get an MRI whenever I do my resections in the middle of or after we feel like we've done all that we can. Intraoperative 3D ultrasound is another new tool that we have that basically gives us real-time imaging and can also allow for re-registration after brain shift. What happens after the brain is opened up is that the skull itself is rigid, but the brain itself is actually a little bit jello-like, and so it moves after the skull is opened. And so one of the challenges is following the brain and sort of making sure that our GPS system is accurate. And this is where ultrasound can help us and play a role. fMRI is also one of the more commonly used imaging studies that basically gives us an idea about where your functionality might be, and can help us determine if the lesion is basically involved with key functional things like language, and basically gives me more confidence during the resection to be to say, well, this is the area that we definitely should be avoiding. And another tool that we use on just along with that is diffusion tensor imaging, which basically allows us to see the connections between different parts of the brain. And again, import this into our GPS system and allow us to basically drive through the brain and do a complete resection. And so at the end of the day, this is what you're hoping for. And so, there are other therapies that I won't get too much, I don't have too much time today to get into, but laser thermal ablation, or commonly known as LITT, L-I-T-T, is a new type of technology that has recently come about. And what it is basically if you can get tumor tissue essentially to anywhere past 43 degrees, the cells within the tumor will die. And so this is a new sort of option that we have in our armamentarium. What this requires is basically a combination of an MRI machine and a laser catheter. And we can now take care of deeper lesions inside of the brain. Instead of doing big open surgeries, we can create a more minimally invasive incision, which sometimes can be as small as, a half a centimeter, and get to tumors that are very, very deep in the brain and naturally and previously thought to be unresectable. This is sort of just an example of the sharp transition zone that basically you get whenever we do one of these types of ablations. This is obviously in a sample that's been taken out. And the advantage of this is that you get shorter hospital stays, you get reduced blood loss, less postoperative pain, and an ability basically to provide adjuvant radiation sooner, as well as get to things like radiation necrosis, which is one of the things that can happen after having radiation to a lesion. There are some disadvantages with this as well, but this is something that we consider whenever we're planning one of these or offering this type of treatment to a patient. And so, going back to this curve, I think the hope is that with all the different innovations that we do come up with, that really at the end of the day, we're sort of working together with people like Joe and Christina, and really just trying to push the curve as much as possible as we can towards something a little bit like that blue line. And a lot of it, is rapidly changing. We have newer therapies every single day, and newer options, particularly things like even some of the clinical trials I talked about earlier are being done sort of in adaptive trials. And so these are important things that we need to look towards in the future to come up exponentially in some ways with solutions. And so my hope and dream obviously is to push this curve up to where the blue line is. But I think that'll only come with collaboration with people like Joe. I mean, working on the front lines of basically trying to find chemotherapeutic or understanding the molecular biology of how these tumors move is critical, because surgery is just one component of it. But the reality is that this disease is oftentimes spread beyond that. And so we really need to be focused on, trying to find a way to sort of attack each and every cell in the brain. And so I'll stop there for now. And if there are any questions, I will try to look for them in the Q&A box, and bear with me because I'm new at this with the Q&A box. If there are questions.
Yeah, I think we'll do the Q&A session at the end together. And so thank you so much, Dr. No. We'll go to our second speaker now. We're moving sort of down the Stoop protocol. So we've learned a little more from the surgery side. So our next speaker is Dr. Christina Spears, who's a radiation oncologist with the Cancer Center of Hawaii. She was also born here in Oahu, so we have a lot of great homegrown talent tonight. She attended Chaminade University here and then went on for her medical education at Vanderbilt Medical School. She got both a doctorate of medicine and a doctor of philosophy, her MD and her PhD there. Then she did a residency at Siteman Cancer Center at the Washington University, Barnes Jewish Hospital. I guess finally mentioned that she also did some research at the National Institutes of Health in virology. And so without further ado, I'm going to turn it over to you, Dr. Spears.
Thank you so much, Dr. Ramos. Let me share my screen. Hi, so my name is Christina Spears, and I am a radiation oncologist or a cancer doctor that treats patients with radiation. I work at the Cancer Center of Hawaii, and today I'm pleased to talk to you about radiation therapy for brain cancer, or aiming more to shoot less. And I'd like to thank the organizers for inviting me to speak. So today we're going to talk about radiation therapy for brain cancer in adults and children, as these patient populations have distinct disease types. And interspersed in this discussion, I'll be raising a discussion on targeting treatment. And anytime I do, I will talk, this little orange head will pop up just to signal that, you know, the goal of this talk is to discuss how to provide more effective treatments that have fewer side effects. And lastly, we'll talk about some screening symptoms that may be of interest to the public to know about in presentation of brain cancer. So I'd like to begin with a case study. A 44-year-old man, while on vacation, develops weakness and disorientation. He had a history of a stroke 3 years prior with few residual symptoms. He underwent a medical evaluation, and unfortunately, a brain MRI revealed a brain tumor or a glioblastoma. So he underwent surgery, chemotherapy, and radiation, but unfortunately, his disease recurred and he passed away 2 years later. So if this example sounds familiar, it's because it is. It's our president's late son, Beau Biden. And this just goes to show that, you know, many people, both in the news and people that you have known, have succumbed to brain cancer. And so it's something that affects each and every one of us. So to begin, I'd like to talk about the site of brain cancers and how they can be metastatic and primary. And let me define that for you. So metastatic brain cancers are cancers that have spread from another site of the body, and that is actually the more common type of brain cancer, with more diagnoses than primary brain cancers, which arise from within the brain. Lung and breast is the most common site of origin for brain tumors, and so we'll talk about those first and then move on to primary brain cancers afterwards. For metastatic brain tumors, the first step of diagnosis is often a PAN scan. So you must identify where the tumor arose from to identify how to treat it. And of course, treating the brain is secondary. Biopsies are sometimes involved. But the first thing to do is often to get a scan like this, a CAT scan or computed tomography scan, sometimes a PET scan. These scans are used to identify whether a tumor is located elsewhere in the body. That can kind of tell you what the tissue type that led to the brain cancer is. And while it's beyond the scope of this talk, the next step would be seeing a medical oncologist to discuss systemic therapy. And so this is our first little orange head because I have been amazed just in the last decade how much more targeted and effective systemic therapy has become in comparison to what many people think of as standard chemotherapy regimens. And this has led to more effective treatments and safer treatments as well. So as Dr. No alluded to, any type of brain cancer, but especially metastatic brain cancers, are best managed using multidisciplinary care. So this includes surgery, and he's given you a beautiful introduction on that, systemic therapy, as I mentioned, and then radiation therapy. And what can never be missed is the use of supportive care, not only from the point of diagnosis, but all the way to end of life care. And so my job will be to talk to you a little bit more about radiation. I promise I won't get too nerdy, but I want to start off with a pretty nerdy picture that many of you may have seen in school. Radiation is just a form of energy. So if you look at this picture, as you kind of recognize some of these things like radio waves, microwaves, infrared, visible light, ultraviolet light, the radiation I'll be talking about today occupies the right side. So this is smaller wavelengths, which is a way to describe energy, and higher energy. So basically, radiation is a way we can use energy to commandeer and treat patients with cancer to kill cancer cells. So a way of looking at this is that radiation therapy can be targeted, and you have that little orange head here, by targeting using imaging to an area a tumor is. So you have spatial localization there. And when you apply radiation, radiation causes damage to a number of different components, but the most important is DNA. And cancer cells, unlike normal cells, often can't repair their DNA, and so they're more sensitive to the damage exerted by radiation. Whereas healthy cells, as long as it's below a certain dose limit, are able to repair the DNA damage. This can be even more targeted by combining radiation therapy with systemic therapy that might increase the effect of radiation on cancer cells by depriving them of the ability to repair that damage. And so what this potentially could mean is sensitizing cells in a particular tissue or a particular compartment so that we need lower doses of radiation, which might cause fewer side effects and more effective treatment. So that's very exciting. For metastatic brain tumors, sometimes we do have to treat a large target, and it really just depends on where the disease is. So as part of the workup, as Dr. No mentioned, brain MRIs are very, very commonly obtained to describe where the tumor is, the number of tumors, and the size of tumors. So in this example, you see that high brain radiation doses are in red, whereas low doses are in blue and green. And sometimes because of the number and the size of tumors, we do have to treat the whole brain. But this is not ideal. I mean, giving a high dose of radiation to the tumor makes sense, but giving a very diffuse cloud of dose to the rest of the brain is not ideal, can affect memory, can cause radiation necrosis or scar tissue or inflammation that Dr. No alluded to. And so over time, we have kind of tried to continue to give the necessary dose to the tumor, but decrease the amount of dose spread. But here you can see that while there's more unirradiated brain tissue, you still have quite a bit of volume getting low and medium doses, which in some cases is clinically impactful. So the favored approach for metastatic brain tumors at this time is to treat high doses to the area of need and really minimize where the radiation is going. And so for a patient with a small number of tumors or with very small tumors, this is a more targeted treatment that is going to provide better quality of life, but still provide local control, meaning the ability to control where that cancer is. However, even when the whole brain must be treated, we can still try to target the treatment to make it more effective and safe. So some of you may have heard of the hippocampus, which is one of our memory centers. And we know that it's one of our memory centers because when it's affected in Alzheimer's disease or with traumatic brain injuries, patients lose the ability to make memories effectively. And so this has been studied with radiation therapy, where, as you can see, here's a picture of the hippocampus on the left, and they're called hippocampi when they're impaired. And on the right is a radiation dose wash. So high doses, again, are in red, going to low doses, which are in blue. This is the hippocampus, which I hope you can compare to this one on the left. And here the hippocampus is getting a very low dose. And what they found on this study was when they did so, that patients had much better brain function as tested by cognitive tests and also as reported by patients themselves. And so this has been an effort made to decrease toxicity as long as tumors were not located in or near this organ, and thereby give more effective and safe treatment. So next, I'd like to talk about primary brain tumors, which are the other category. So for primary brain tumors, tissue and gene analysis is critical to determining the best and safest treatment. This is not a pathology talk. I'm not going to get into too much detail. However, the first best step is to have a pathologist identify what is the tissue type for this cancer cell. Is it a brain tumor, as Dr. No was discussing, and those break down into further categories, or is it a supportive cell or a non-brain tumor that still is located within the brain? Each of these can lead to cancers, and each of these are managed in a different way. But something that has been the leading edge of research by researchers such as Dr. Ramos is looking at, what can we identify beyond just the tissue type? What are perhaps the changes that are associated with these less aggressive and more aggressive tumors? What drives growth of these tumors, and how does that correlate to behavior? So there's a lot of text on this slide, and I don't want you to focus too much on the text. Just follow this side where it says lower grade gliomas, which are less aggressive brain tumors or brain cancers. And each of these has genetic signatures that correlate with the less aggressive behavior. And so this has been incredibly important to subcategorize these tumors to identify where can we de-escalate treatment, where can we omit radiation, and where can we potentially just watch patients after surgery. Whereas on the right side with these high-grade gliomas, it's so important to find these driver mutations that can be further targeted with therapies that might improve the efficacy of treatment for these aggressive tumors while still minimizing off-target effects and specificity of treatment. So we talked about adults and we talked about primary cancers. I'd like to then move into children. So I am one of the pediatric radiation oncologists at our center. And so just a little bit on pediatric and young adults. They have very different brain cancers than adults do, but the general approach is the same. We start off with identifying what is the tissue subtype, where did the cancer arise? So here is a really beautiful schematic looking at the top of the brain, the back of the brain or the posterior fossa, and of course the spine. And each of these subsites gives rise to different tumor types, which can then be associated with different genetic changes and different behaviors. So this subcategorization is so critical to identifying what the best treatment is. But again, it doesn't stop there. We want to find what are the genetic changes, what drives growth of these tumors, how can this be from bench to bedside a leaping point for better, safer, targeted therapies. So going into my second case study, a 13-year-old boy presents with 3 weeks of morning headaches, vomiting, and imbalance. His parents become very concerned and bring him to his primary doctor. An MRI is done, as you can see here. This is a horizontal slice and shows this abnormality in orange near the cerebellum or the back of the brain. And so this child was diagnosed with a medulloblastoma. There's a lot of information on this slide. I just want to take away 3 points, which is that medulloblastoma is one of the most common CNS tumors in children. It is a cancer that arises from the cerebellum, which can also spread to the spinal cord. That impacts how we treat with radiation. And here, that the area of the brain in which these tumors arise associates with the risk stratification and potentially the genetic drivers, although there are some genetic predispositions in this group of patients. However, the most important part of this slide to me is this group on the right, where you can see there are 4 different groups which are broken down by the genetic changes that may be driving carcinogenesis or development of these cancers. And in some of them, we can potentially de-escalate therapy. Think about reducing or omitting radiation. Whereas others, where there is higher risk of metastasis, it's important to identify these so that we can do targeted therapies more early on to decrease the chance of metastasis later on. So medulloblastoma is again best treated in a multidisciplinary fashion with surgery, chemotherapy, and radiation. And just moving along, I'm going to talk about the radiation part of it, where, as I mentioned, because medulloblastoma can involve the spine, we treat the brain and the spine. And so this is, as you can see in this figure right here, a very large volume. Traditionally, we would treat the brain and the spine to a medium dose, treat the area where the tumor arose to a high dose. But I hope you can appreciate here in blue and green how much of this child's body gets radiation exposure. So this is moved to using, in children where this is appropriate, proton therapy. Proton therapy is another modality of radiation, different than the hard X-rays that I talked to you about. In this type of therapy, we are able to stop radiation exposure in tissues, meaning the dose exposure can be stopped in tissues, and that leads to a larger volume of unirradiated dose. So if we look at this child who has received proton therapy to the cranial spinal region, this still allows for a significant volume of tissue that is not radiated, which can potentially decrease the risk of future growth effects or cancer from treatment, and among other possible side effects. This continues to be evaluated, and there is still ongoing research to determine if we further refine our volumes and decrease even the vertebral column, do we then see better outcomes as well? So this is something very exciting in radiation oncology and something that we think is really important with pediatric cancers. As you can see, pediatric cancer management is incredibly complex, and so I believe that these patients are best managed on a clinical trial. As I said before, bench to bedside, where the most exciting research coming out on these cancers is then brought through multiple phases of a clinical trial so that in phase 3, we compare it with the standard of care so that we can identify what are the best treatments that actually improve outcomes before FDA approval. However, I don't want to be too optimistic about this. There are still, significant long-term follow-up that is needed for these children. And so I just wanted to alert the public's attention to the Children's Oncology Group, where there is multi-system long-term follow-up that assists clinicians in following these children after they undergo these complex treatments. So just in the last couple of minutes, while there are no screening tests recommended for the public for brain cancers, I just wanted to identify a couple of symptoms that may alert you or your family member to seek medical advice. And these can be subjective changes like appetite changes, balance, motor or sensory changes, or objective changes like loss in weight, changes in vision, and neurological testing changes. Cytocare and Moffitt Cancer Center have put together these two really nice graphics, which are nice reminders of these symptoms, including headaches, nausea or vomiting, issues with vision, hearing loss, issues with balance, sleep-wake disturbances, confusion, seizures, trouble swallowing or controlling your facial muscles, prolonged unexplained fatigue, and other symptoms. And so for my last slide, in summary, brain cancer is best managed with targeted treatment that improves outcomes and minimizes side effects. I hope I've convinced you of that. And as the subtitle says, that we really want to aim more to shoot less. And so that's some of the examples that I've raised are using better molecular and genetic targeting, which has come such a long way and is so exciting. Using radiation sensitizers so that perhaps we use lower radiation doses, while also potentially increasing specificity in tissues or compartments within the body. Using better imaging to target radiation in a more precise and accurate fashion, and hopefully using smaller targets in order to improve quality of life. And shooting less includes finding risk groups where we can de-escalate treatment and either decrease radiation dose volumes or even omit treatment. Spare organs so that patients have fewer side brain radiation therapy, and identifying modalities that are appropriate for use where we can get really good outcomes but as few side effects as possible. Thank you so much for your attention, and with that, I'll take any questions.
Great, thank you, Dr. Spears. We're going to move into our Q&A session now, which will have all of the panelists available for your questions. So please, I encourage everyone, if you have a question, to please type it into the Q&A. Again, that should be in the bottom of your Zoom screen, right to the right. It has a little number 2 on it now because we have our 2 first questions here ready to go. I think everybody's learned how complex this cancer is and how many different kinds there are and some of the things going on with the advances in treating it. We have our first questions over here. Dr. Spears and No, can you see the questions or would you like me to read them?
No, I could see them.
Okay.
Yeah.
So our first question is from an anonymous attendee. I'll read it for the group. This attendee says that their mother was diagnosed with glioblastoma at the age of 83. She declined treatment and passed away 3 months later. The questions were, 1, her general health was good. Had she accepted treatment, surgery, chemo, and radiation, how severe would this process be? In other words, what would have been her quality of life? What would have been her average life expectancy then? And then secondly, are glioblastomas hereditary?
I can maybe take that question, because this is a conversation that I have many times because I'm usually the first person to see these patients when they first present, oftentimes with, as Dr. Spears said, with a variety of symptoms. But the first thing that I always bring up is, how would they want to be treated? And oftentimes, the most important piece of all the treatment that we do is that it's a partnership, right? It's me being able to give information and sort of say, well, look, we know with even surgery and chemotherapy and radiation, even with the best treatments that we have, your average survival may be 12 months. And so, we can certainly take a gamble with that. And sort of the upfront risk to some of that is surgery and some of the side effects that may come from chemo and radiation, which you can certainly also stop along the way. But they may come at a certain price. And some people are very much on board with sort of being like, yes, let's do everything possible. And there are just as many people who say, well, I've lived a good long life, and I'm sort of happy with everything that has turned out the way it has. And so, even though it may be 3 months, I'm comfortable with 3 months. And so, I think that's one of the hardest parts of my job sometimes, is sort of really trying to assess that. And sometimes it is sort of a skill, but it's really just, I think it's just becoming friends sort of with the patient and trying to manage their expectations in some ways with what might happen.
Dr. Spears?
I agree with everything Dr. No just said. In terms of the radiation, it tends to work alongside with chemotherapy. So it's a discussion alongside the medical oncologist and the patient, and of course the family, to try to set expectations, to determine, what is their baseline, how has this treatment, or how has the tumor impacted their baseline function already, and how does the family feel about that? In terms of glioblastoma, the treatment can extend to all the way to 6 weeks of treatment. That's a lot for some families and patients to swallow, because it is daily treatment, and they do get significantly tired anytime you treat the brain. Fatigue, among other side effects, is huge. And sometimes it's having that discussion, as Dr. No said, that you're gonna, even if you feel better at the end, or even if we stabilize things at the end, overall the prognosis is not great, and oftentimes with the treatment you will feel worse before you feel better. And so once families know what to expect, while still understanding that every person is different, then they can kind of frame their expectations. There have been studies suggesting that if we shorten the radiation, so instead of 6 weeks going to 3 weeks, or sometimes even shorter, that we can still often get good outcomes. And so I think talking to families at that level, saying, okay, maybe we're not doing the 6 weeks of treatment, but if we wanted to stabilize growth, do you think you can take on 3 weeks of treatment? And sometimes that's exactly what they want to hear. But I think what we try to do as a multidisciplinary team is always be open to the idea that just other decided, that they don't want to do treatment, or they want to stop treatment early. And I think that's part of this whole process.
Thank you. I remember her second question was, are glioblastomas hereditary?
There are certain syndromes where gliomas are a part of that, and I'll be honest, those syndromes are oftentimes very rare. But in terms of actual very sort of common types of things, that's almost a case by case sort of thing, because there certainly are family linked history types of gliomas, but at the same time they're very, very rare, and so that always comes up almost with on a geneticist's radar, for example. But so in other words, to answer the question, yeah, there are some forms, but not very common.
Yes, very, very rare ones. So our next question is also from an anonymous attendee. They've read about the hope of raising antibodies to glioblastoma. Why hasn't this been successful? And is there not enough time? That I guess they're proposing a possible answer there. But I think this is basically what kinds of immunotherapies, ways of using the immune system to treat glioblastoma have been checked out and tested and may be coming down the line.
Yeah, I mean, that's another interesting question. I mean, I guess I like to answer that one because that's the clinical trial that I'm currently running actually at the Cancer Center, is using immunotherapy to see if this is a good potential way of increasing or providing a better prognosis. In terms of raising antibodies, for example, through like xenographic models and things of that sort, we know that, oftentimes we can raise these antibodies, for example, even in animal models, but when that's applied to humans, for some weird reason, there is not a translation, and we don't quite understand why. Again, I'm not an expert in that field, but that's what I've read and sort of understood in trying to raise antibodies.
I think there was the DC Vax trial, which is still pending maturation, and we don't have good results from that. My understanding, and Dr. No would be much better at answering this than I, was that in enrolling patients on this trial, that a significant size of brain specimen was needed. So just in terms of having patients go through that, some of them were not eligible. And it takes time, as the questionnaire indicated, to raise these antibodies and then, of course, to use them in the patient. I think early findings were promising, but we're still holding our breath for those results. But as Dr. No alluded to, stimulating the immune system can come through a wide variety of ways, and that was one of the approaches.
Yeah, I can note, having seen a lot of grants in these areas recently, there's a lot of work still going on in this area. So there are new attempts to try and improve vaccines and that line of attack. There's actually some new CAR T therapies where you engineer your T cells to attack the tumor that are being tried again. And then the checkpoint inhibitor, these other ways of increasing the immune response, which have not done great so far, but there's more and more activity to try and figure out how to make them better. So maybe we'll still see some really great new advances in that area down the way. Okay, we have our next question. This one is, how far along are we on CRISPR-LNP to treat brain tumors? Can you explain what research is being done on this? Anyone want to take a stab at that?
I was going to say, I feel like it's a question Joe might be able to answer.
I haven't seen anything so far that, in the CRISPR realm for brain tumors. I was curious if either of you had seen anything coming down the lines, but that's not an area that I'm aware of any new results on yet.
No, I mean, that's it's taking me back to nostalgia, back to my PhD days, because this is, gene editing. And while it's very promising, I am also not aware of any mature data that I think would shortly make the leap to the clinic.
Thanks. Another question, anonymous attendee. Someone said, thank you both. It's not a question, it's a comment. Thank you both of you for a wonderful, approachable presentation. I would echo that. Okay, another question here. Are there any specific genetic mutations that can alert for the potential of having brain cancer, like BRCA2 does for breast cancer? That's a good one for you guys. So Christina, sorry, please go ahead.
Oh, sorry, no, I was just going to say it's somewhat similar to, I think, the question we had earlier, which was, about hereditary syndromes. And while they do exist, I think they're very rare. And it's a question that we get often is that, do I need to test my kids? And I think the sort of short answer that I usually give is, this is very, very rare, unless there were some other odd things that stood out, like particular types of skin cancers or things like that. Then we wouldn't be worried and we wouldn't recommend that.
So if I can keep track of the points in my head, I wanted to raise three things about this. And one is that, for the slide that I showed for pediatric brain cancers, there are familial syndromes such as Gorlin syndrome, which is in the hedgehog pathway. And so again, these are quite rare, but especially in childhood cancers, it may be something that parents choose to follow up on. However, my second point is that, sending every child with childhood cancer to a geneticist, there's significant ethical implications there, not only for the child, but also for family members. And that's something to always keep in mind. The third point I wanted to make was just adding to what the others have said, in that in adult cancers, we're still continuing to find these out. So whereas BRCA1 and BRCA2 were the first well-known and identified breast cancer mutations, we know that data on breast cancer is coming out all the time. And there are constantly evolving classifications where things may not be associated, but that may change in the future as we get more information and more data. And there was, I was doing a literature search a little bit earlier today, and there have been There's a study in the UK which identified more mutations that can be associated with brain cancer. So I think that the true answer is we don't have any clear association yet, which is good, and brain cancers remain less frequent than breast cancers. But I think we're constantly refining our understanding of what may be associated with these cancers.
Yeah, that's one of the challenges of early diagnosis. We don't really have anything great for doing that, unfortunately. So these tumors have already progressed so far by the time doctors Ngo and Spears see them, that it makes it much more challenging to treat. Okay, our next question. This attendee says that they viewed a video by a neurosurgeon from Penn Med who talked about using gamma knife therapy for glioblastoma, which he had copyrighted. So do you all have any comments about gamma knife therapy?
That's a great question. So there are some people who would recommend that, and it, again, this goes back to sort of more of like a case by case type of basis. And I think, there certainly are people. I can give you a good example, a patient, for example, who does not want to come in for multiple treatments and would rather have, no surgery and would prefer just one treatment, option that was quick, and then they wanted to go and travel the world and do their thing. They didn't want chemotherapy or anything like that. And that certainly is an option. It's, again, I think every case is sort of a case by case type of thing where you're really trying to figure out what is it that you want, is it something that that you're okay with staying around for and sort of going through multiple treatments? Are you okay with chemotherapy? Are you okay with surgery? Or it's really a conversation, I think, that you have to have.
I absolutely agree with that. I think having that discussion with patients, but also making it clear when something is the standard of care and has a lot of data and recommendations behind it versus when something is an alternative approach. As long as patients understand that, I am always willing to have that discussion to be in line with their wishes and their desires for their own, this is their own life. Most of the time when we use gamma knife, it's if they've already undergone standard therapy and perhaps there is an area that's small volume where we think we can give the high doses that come along with gamma knife in a small volume safely. And so that's where I've seen it more commonly used. I will give you the historical precedent with radiation where we went to really, really high doses on these tumors, higher than we typically go to nowadays, and it really showed no benefit. So in terms of asking whether gamma knife might have beneficial results just because you're potentially going to a higher dose relatively, I don't know that that's in keeping with the behavior. But if, as Dr. Ngo alluded to, for other reasons, the patient wishes to have quality of life and decrease the volume of radiation to the brain, it's something that can be discussed.
Thanks. Our next comment and question. Great presentation, Dr. Ngo. What are your thoughts on the use of gliolin in the use of adult malignant brain tumors?
Oh, gliolin. So gliolin is basically a recent development in brain tumor surgery, and that labels GBMs because it uptakes a particular type of chemical and then turns it into something that you can actually see under a microscope. And it's a very great tool. And I actually took out the slide in my slide presentation because I didn't want to get too complicated with it. But it is something that I like using. And in particular, the best way that we use it is it's a solution that the patient has to drink a few hours before surgery, but during surgery, it basically lights up the tumors to a really beautiful type of pink color that allows you to see where the tumor is in the brain. And so it's a great tool to have, oftentimes expensive, but still one of the tools that we have in our armamentarium that's a great tool. And we sort of hope to eventually at some point get it here in Hawaii as well.
Great. Next question is for Dr. Spears. How new is proton therapy, and is it offered to children here in Hawaii?
So proton therapy is not new. It has been used since the 1970s. One of the places that it's been used very frequently is one of the places that Dr. Ngo trained, which is in Harvard. I would say in the last 5 to 10 years, its use has spread to other places nationwide and of course worldwide. I talk to patients about, or I talk to their parents rather, about protons, but I try to be careful about that discussion. Not everyone has the resources or the ability to go to the mainland and get treatment there. And protons do not have indications in everyone. There are certain types of tumors, even in children, where there's been shown to have no benefit. There are, a proton specialist can tell you certain risks that may be higher with protons. So it's not a clear cut, everyone should get protons all the time. And with adults, it's even more controversial. And the treatment is very, very expensive. So I have a discussion with the parents. I try to counsel them on what the potential benefit will be, offer them a consult with a proton specialist if they're interested. But I never want parents to feel like they're depriving their kids of something if they just can't take them to the mainland to get treatment. So I always try to approach it as an option rather than a mandatory thing to do. And especially since sometimes the data is more speculative than actually proof.
There's a question that I think you hit on most of it, but it's another one coming up in just a minute. That I know Hawaii does not have proton beam facilities. Under what conditions would you recommend transporting patients for PBT, such as at La Jolla or MD Anderson? And also, what are the trade-offs between using SBRT and PBT?
So for the first question, it's a matter of determining what are the parents' wishes. Do they prefer to have their child here? Are they okay with traveling? Do they have the resources to travel? If they're fine with that, we have a program where we've sent children to Seattle Children's, to Rady's in LA, to St. Jude's. But really, I ask the parents. We have these existing programs. St. Jude's is wonderful. If you go on a study, then they will pay for everything. However, to get to one of these places, in some cases, takes up to 6 weeks, and sometimes that's time that with brain cancer we really don't have. So I always try to set expectations with it may take some more time, and is that something that everybody on the medical team is okay with? So that's that question. From the standpoint of proton beam versus SBRT, two very different modalities. SBRT is high doses to a very small volume, and that's not always what we want with protons. Sometimes with protons, it's actually a very large volume. We're just trying to stop the area in the tissue, and that actually does lead to increased variability. So it depends on what the context is. You don't always want protons. You don't always want SBRT. It depends on the tumor type and the disease context.
Great. We had a question, I think must have been typed before your slide, Dr. Spears, about what the warning signs are and symptoms. So I think we can jump over that one. And we have another one here about genetic profiling, and we just answered, I think you guys have answered that one pretty well. About there being very little that we can do in terms of predicting tumors based on genetic profiles. Someone asked about Alzheimer's disease, hereditary. Is it hereditary? And are certain adult brain cancers more common in certain ethnic groups? With the ethnic groups question, it's not clear that there are any major differences in ethnicities in Hawaii, at least. Although white patients tend to have a little bit more, and then Native Hawaiians, and then our Asian populations. But there aren't huge differences as far as I'm aware. So this one is and we probably aren't going to get through them all. Trying to get through as many as we can, but they will be. We will be available. You can send questions in later, and definitely take a look at the website to take another look at the slides and the talk. This one is 5 years ago, a patient fainted. Radiologist diagnosed the patient cancer due to lesions in the frontal lobe. Further scans ordered by the oncologist did not show evidence of metastasis. The patient recently diagnosed with dementia, which had similar symptoms noted earlier. What are your recommendations? Should they talk to an oncologist at their next appointment?
Yeah, it would certainly. I think the number one thing that you can do is to partner with your primary care provider, because that really is the gateway and sort of key to really figuring out what's wrong. And, you know, while we're experts here, we oftentimes see patients that have already been filtered through a really big system. And so the number one thing, even going back to an earlier question where you're looking for signs of brain cancer and those types of things, you know, the number one thing you can do is have an ongoing conversation with your PCP, your primary care provider, and really letting them know, gosh, you know, something is a little bit different or something is a little bit off, or maybe this isn't right. You know, do you think we should get a brain MRI? You know, and especially in a place like Hawaii where insurances can be challenging to get imaging even in the first place, that makes the conversation with your primary care provider even more important because that's how things can get missed, is if there is not an ongoing conversation. So really, I think that's where things should start, and where patients should have sort of a really good established relationship is with your primary care.
Great. Maybe just two more questions. This one, though, I think we should hit because I've heard this one every time I talk about brain cancer. Are there any lifestyle choices that increase your risk for brain cancer?
I would argue that some of the patients, that most of the patients that we've seen who've been diagnosed with brain cancers are like the healthiest people you have ever met, right? They're prime of life. They exercise more than I do. They eat really well. Not that these things are causative or preventative, but it's not a certain type of patient that comes in, I think. And I'd love to hear what the others say.
Dr. No, any comment on that one?
Nope, just that I agree.
I agree as well. And that's my usual answer. There just isn't anything obvious. So I think we'll close with this question because I like this one as our closer. How do you keep going on fighting this awful, terrible, challenging cancer?
You know,
I mean, have to save these patients. Yeah.
Yeah, no, at the end of the day, I mean, this is why really, I mean, you know, what it comes down to is patients, right? I mean, these are the people that we see day in, day out. These are the people that we live next door to. And so that's really what keeps me going. And really what sort of makes me even more of a proponent for things like, you know, helping people like Dr. Ramos, because we need people like him to be fighting on the front lines of figuring out a cure for this thing, you know. And in a lot of ways I tell people, gosh, you know, I'm here just trying to sort of take care of the frontline stuff that comes through, but the people who are doing the Manhattan Project in the back are, you know, are Dr. Ramos. And that's really where our attention and where most of our resources really should be put towards.
Dr. Ramos, please. I'd love to hear what you'd say.
For me, it's just one of the most challenging things. When you're going to commit your life to a certain type of research, you have to ask yourself, there's only so many hours in the day. You know, what are the most challenging things you can work on? And brain cancer is one of the most challenging cancers. There's so much about it that makes it hard to treat. Dr. No mentioned the blood-brain barrier. That makes it hard to get drugs into the brain, for example. And he talked about the ultrasound as a way of getting around that. So for me, it's just where can you have the most amount of effect for the time that you put into your limited life of research. And so that's why I've really focused on this particular cancer. Dr. Spears, though, you know, what would your answer be?
I mean, you guys have said it all. I would just end with, you know, it's a privilege to treat patients that have brain cancers. Not to diminish any type of cancer, but you know, the brain is the seat of our personality, and to help patients fight for that, for their quality of life, and to continue feeling the way they do, to continue interacting with their family the way they want to. That's just an honor to be a part of that process. It's difficult, but as difficult as it might be for us, it is so much harder to go through it or to see a loved one go through it. So we actually have an easy job in the relationship.
Thanks. I'm going to bring the webinar to a close. I want to remind our participants that they can take a survey that's there in the chat box, and that you'll get the email sent to you soon as well. I also wanted to note that we will continue the Starlight Lecture Series. The next one will be on June the 24th, again at 5 p.m. That one is going to be on cancer and diabetes. So I definitely encourage everyone to attend that as well. I want to thank Dr. Spears and Dr. No for teaching us so much today and for spending this hour with us and giving us some insight into this really, really challenging cancer. And with that, I'll close out the webinar. Thank you all for attending. Take a look at the Cancer Center website. You'll get the lecture there and you'll get the slides as well. And thank you all. Thanks, Dr. No and Dr. Spears.
Good night.
Good night, everyone.